We're fine. I think you just need to press the presentation button again.
Okay. Sorry. Good morning and good evening, professor and colleagues. Today, I will represent a complex case of polytrauma involving a 21-year-old man who sustained life-threatening injury in high-velocity collision. This case underscores the challenge of managing multi-system trauma and the critical role of multidisciplinary collaboration. So, on February 25, 2025, 6 and 2 a.m., a drunk patient crashed an electric scooter into a cart, and she brought in by ambulance. So they have a facial abdominal limbs options, and she had vomiting, agitating, and prepubic lacerations on both legs. So we have a primary trauma assessment reviewed. Airway is vomiting, and the breathing spot O2 is 97, and circulation pulse 89 and BP 99 or 49 mmHg, and disability GCS 456, and explosion open bilateral tibial fractures with multiple facial, lip, and abdominal abrasions. So we have the initial management about airway. We have used the endotracheal intubations, and about the circulation, we support 1,850 meters crystal rescutions, and we do the peripheral head CT and the whole abdominal CT and the chest CT. Is about on the right is about the fractures. You can see that here is open bilateral tribal fractures is distal 3A. And about the chest CT. One of no stereo contusion or scalp fractures, and we can see the chest CT with small right pneumothorax and the pulmonary contusion. And we have the abdominal CT. You can see the stone-born wall stinking, and we have the little intra-abdominal gas, very little, and no obvious soil organ injury. And the patient's abdominal is soft and no complaint of abdominal pain. So how about the next treatment?
Okay, so yeah, let's stop here first. Yeah, so first of all, Reilly, so for this patient, do you have any comments at the moment?
Well, sure. I guess a couple things. Number one, the fractures are pretty significant. I'm sure you'll get his patient will get tetanus and antibiotics as you get ready to deal with the fractures. The small, I guess you'll call it an occult pneumothorax on positive pressure, gives me a little pause. If this patient's going to the operating room, to have both of their tibias fixed, you need to make sure either your anesthesiologist is really keeping an eye on the patient to make sure that the peak airway pressures don't increase and there's no signs that the pneumothorax is getting bigger during the case and even causing hemodynamic compromised if it would be develop into a tension pneumothorax, or you could be very aggressive and put a chest tube in it. In this day and age, I think the CAT scans are so sensitive. We all have treated some of these, and just in an observational standpoint, in patients have done all right. And then the million-dollar question is whether this patient has a hollow viscous injury related to the crash. The CT findings are very soft. You're not giving us on the cut, you're showing us any fluid to go along with the small bowel thickening and the small amount of intra-abdominal gas. If the patient was really intoxicated, the fact that they have no abdominal pain, I take with a grain of salt, and now they're intubated, so your abdominal exam is gone. So that's going to be a real challenge for you to sort out. Pat, you got any thoughts?
Yeah, no, I second all those. There's some degree of small bowel wall thickening there that's worrisome, and especially in this setting. And to your point, he's intubated now, like sedated and drunk, and so his exam is meaningless, I believe, at this point. In addition to that, we have to worry about a head injury, whether his CT scan, the head is negative per se or otherwise. That may not demonstrate fully the extent of a traumatic brain injury without intracranial hemorrhage or without significant edema at the time of the scan being performed. And so a patient who comes in vomiting with a very low GCS that required airway protection with intubation, that's something we want to continually reassess, and that can easily get lost if someone goes to the operating room for a long time or stays in the ED for quite a while. And then last, I think he got around 2 liters of fluid, which is just fine. In advance of a CT scan being performed with some relative hypotension, we would likely end up starting with blood at least, and hopefully having a CT scan performed very rapidly. After which, if there's not bleeding, certainly consider what types of fluid to administer other than blood after that.
Yeah, thank you.
Is that Professor Huang down there too?
Yeah. Professor Huang Wei.
Hello. Good afternoon, everyone. I'm sorry that there is maybe some problem with my net, and I'm late for 5 minutes.
No issues.
So, do you have any comments at this point?
Yes. Maybe we often see some patients like this. Maybe in our trauma center, I will repeat for CT scan after 3 or 4 hours. Maybe we can see some different with this CT scan.
No, I think that's a great point. I mean, serial CT scans are certainly something that's described in bowel injury. If they had fluid, you could try some kind of DPL and try to sample what the fluid is, or there's all kinds of pathways to try to sort out hollow viscous injury after blunt trauma. And then the other thing I would just mention for the youngins in the group is, boy, those fractures look pretty bad. Even though they're open, they look like the kind of things that could wander into compartment syndrome in the future too. And just remember, trying to diagnose compartment syndrome in an intubated patient can be more challenging than it should be, because the patients tend to not complain of pain because we're giving them all these medicines to keep them comfortable in the bed. And if you don't complain of pain, sometimes it's not at the top of our list to look for compartment syndrome in an injured extremity.
And to follow up on the abdominal discussions, I would go as far as to say, based on the information we have here, I would put a laparoscope in this patient and just look early on, as opposed to trying to perform serial CTs versus exam over time. But that's, I think, all a matter of preference and context and resources.
Yeah. Also, Professor Reilly, if this patient in your center, so are you going to manage?
Okay.
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 Yes. So
So with the next treatment, they transfer to the ICU, and the patient sent to the operating room for the debridement of the open tibial fracture, application of an external fixture, and closer reduction external fixture of the tribal fracture directly. The surgery conclude at 22 and 29. On the SU day 2, February 26th, and the patients has a system. They sudden onset severe right lower current pain, and they have a perineal signs and guarding and rebound tenders, and we can see the cities. They have a reduced bowel, small bowel perforations, and we can see the next treatment we have a emergency explore laboratory. So we can, so first, we found the abdominal exploration. We have found a 100 ml purulent fluid, and we sent to cultured, and we can see the small bowel contusion with perforations, and 65 centimeter from initial value, and we can see the 6 centimeter centric defect with ischemic bowel requiring resection. So we have a linear stammer resection of perforance and devitalized bowels, and side to side anastomosis and Hansu, and we have a re-revelation have no injuries in commerce, stomach, liver, spleen. So we have closed the abdominal and put closer suction drains and perihepatic and plebic. So we repair of corner and small intestine, side to side anastomosis of small intestine, 2 segments. So repair of small intestinal mastery and corner mastery.
Okay, and Dr. Lee, please stop here. So
Okay.
plus, go back to last slide. Yeah. So okay, you can go to next slide for the patient. Next slide. Next one. 下一张那个病人的，有那个病人的整体的那一张。The whole patient one. Next one, next. 下一张 next one.
No, it's cool. Well, let's. Hey, Pat, let me ask you a question. Do you go and you do a lap on a patient like this, and they got pus in the abdomen? Do you culture it?
I do not. No. It's gonna go poop. It's poop. So
yeah, we have a VREC problem, and I like culturing it, and I sort of know what I'm going to give them empiric antibiotic wise. But if VREC ends up growing out post-op day 2 or something from our thing, then I adjust the antibiotics based on that. And that, you know, I ask my residents whether they're doing it or not, and they're 50-50. Some don't. Dr. Huang, do you culture purulent fluid in an abdomen when they have an obvious perforation? Well, it's certainly, I don't know, certainly interesting concept.
I think for a fresh trauma who presumably has no exposure to significant healthcare related bugs, but certainly in our EGS patients or folks who've been brewing in the hospital for a while, we do culture in that setting.
Yeah. Pat, do you want to take that text message that just came in the chat? Because I think that goes to something you mentioned.
Yeah. So to that point, actually what I thought of, especially if that patient was going to the operating room, was going to undergo the risk of general anesthesia to have their legs worked on, that's a great opportunity again to put in a laparoscope. If you find nothing, it's 3 5-millimeter incisions. If you do find something, you can avoid at least some of this in terms of contamination and whatnot. And with those initial findings, and again, the inability to truly examine that patient, would be a reasonable thing to do. We always try to err on the side of looking on these types of patients. And Dr. Reilly's point is correct. It's the $1 million question: is do they have an intra-abdominal injury? Don't they? There's a number of different papers that look at scoring systems, the BIPS score, et cetera, that may lead you to operate earlier. Those are all imperfect, and there seems to be a new one kind of each year. And that's where, your clinical gestalt and really matters when it comes to these patients. But I would always say err on the side of looking rather than not, especially in a sick polytrauma patient who has other things going on too.
Dr. Huang Wei, and just Professor Reilly asking if this patient in your center, do you do the culture, if you do the operation?
In our center, we also will do laparotomy, because we think that if the patient is hemodynamic instability, laparotomy is more quick. And for patients such as this, like this, if we do laparoscopy, maybe we will miss something. So we every year about less than 10 patients we will do laparoscopy. Thank you.
And that's a good question, Dr. Reilly. Would you ever do a complete abdominal exploration for blunt trauma if there were some positive findings, like in this patient? Let's say you had the laparoscope in and you looked and you saw this bowel injury. Would you ever say you have a complete exam with laparoscopic instruments only, or are you automatically opening to a laparotomy at that point?
I would say I have a complete exam with laparoscopy and a CAT scan that shows you things ahead of time. I think the combination of those two is pretty good. Can you, we tend to want to do things in a rapid fashion because we have a lot of priorities that aren't necessarily lend themselves to a 3-hour surgery. And so you have to convince yourself you're going to run the small bowel from the ligament trace to the ileocecal valve, which you can do quickly open, but laparoscopically, even for my more facile colleagues than I am, takes a little bit more time. And you worry there's a nook or a cranny that you don't get a good look at. But I think if you have a CAT scan ahead of time and there's a directed area that you want to look at, that's why I think your idea of laparoscopy is a very good one to try to move things along as you get ready to fix these guys' open tibial fractures. Does anybody give a dose of antibiotics for that intubation in the trauma bay? In and of itself, is that something do you believe that, like Lancet respiratory article, that especially in brain injured patients, that it decreases early pneumonia rates?
We're not doing that. And in fact, we actually have a new guideline that is being made in conjunction with our ID team that we're calling trauma antibiotics, which is going to be a kind of catch-all for everything in trauma to try to including procedures like chest tube placements and intubation. And so that's all being explored currently. We don't do it at Duke, for example, as an empiric measure. We do a single dose with the chest tube, for instance, but not with intubation.
Yeah, we've started. We had a TQIP, pneumonia rate that we weren't happy with. So we've added it to our, especially in our brain injured patients, given that single dose in the trauma bay. And, I don't know, we'll see over time whether it has an impact or not. Our ID guys weren't too excited about it. And I got to be honest with you, they were also unaware of the literature that supported it. They were sort of putting up we don't want to give anybody antibiotics ever. And then you consult them and they order antibiotics you've never heard of and give them for weeks on end. I don't. But don't get me started on my ID colleagues. I love them and I hate them.
Yeah. Okay. Thank you. So let's move on. Yeah, Dr. Lee, please.
So he in ICU management about the intra-abdominal infection control. As fungal and gram-positive pathogens, we use the broad-spectrum microbiome therapy and a tailored regimen based on AST, declining inflammatory markers, and we use the pulmonary infection management, reduced infiltrates on CSR, and stabilize labs continue, and we continue pulmonary rehab. So PE management, the CTA shows a comfort self-segmented PE, and we use the anticoagulations initially. But in the post-operative day 4, we can see we repeat CT and we can see the dilate small bolus with a luminal gas and with possible obstructions, and we use the gastric tube in decompressions, and we close the monitoring, and so the result, the patient reduce abdominal distension and symptomatic improvement. On the right picture is about the patient's wound conditions, and the patient clinical stable with a result abdominal wound infection after conservative management was transferred to the orthopedics department on April 13, 2025 for definite surgery interventions. And you can see the white red blood cells is about higher, and the inflammatory markers is declining.
Pat, are you guys routinely measuring IL-6 and things like that?
Yes, in the ICU.
Patrick, are you?
No, not routinely for this type
we're
of
not.
setting.
My wife works at the Children's Hospital, and they have an inflammatory marker panel that they run on diagnostic dilemmas, for lack of a better word. That's fascinating. That it's fascinating stuff, but we're not routinely using it. That's this is very interesting to me.
Okay, let's go on.
Is there? Can I ask a question, Dr. Zhang? Is ERAS protocols for trauma laparotomy? Is that something we're all going to be doing in 5 years? What do you think? Anybody? What? Enhanced recovery after surgery. The things, our colorectal surgeons and whatever are doing for elective surgery, or where I know the guys in Europe have, have a little body of literature on it for emergency surgery or whatever. I worry our patients don't all fit into the same basket, and trying to really push them along from a recovery standpoint. A patient like this who's got both his legs all busted up and everything, are they going to really react the same way that somebody who has an isolated stab wound to the small intestine is going to act? I'm skeptical, but it's something that I think is people are going to be looking at.
Dr. Reilly, I'm skeptical as well. This backfires quite frequently, even leading to aspiration events, et cetera, when you have a multi-system, especially blunt injury with a legitimate exploratory laparotomy. And not to mention, if you have other injuries like this with being laid up and treated with likely some degree of narcotics, et cetera, these polytrauma patients tend to have really bad ileuses. And sometimes they don't. Every now and then they don't. And we like to try to use the gut early. But it will oftentimes backfire. And so, yes, I think to your point, Dr. Reilly, you mentioned like a single stab wound or something. That is oftentimes a different beast than a blunt polytrauma patient.
Yeah, we'll see. A lot of pressure to minimize length of stay, I'll tell you.
Okay, can we move on? Yeah, Dr. Li, please.
Also, you can see the some markers is declined, and AST and ALT is declining. So we have some message. If abdominal explosion indication, how about the CT shows little free gas and no periodicize? Should we proactive laparotomy to prevent delayed paradise, early diagnosis laparoscopy to avoid missing intra-abdominal viscous injury should be considered?
Yeah, I think that's a very important take-home message. I'll ask Pat this first, and then we can ask Dr. Huang too. You think that initially you go and from the trauma bay you go upstairs and you see this injury, you think it would have been something that you could have treated laparoscopically? Laparoscopic small bowel resection and clean that up if the mesenteric defects aren't bleeding, because it sounds like there was no free fluid on the initial CAT scan. It sounds like they weren't really bleeding significantly. I mean, diagnostic laparoscopy is one thing, but therapeutic laparotomy and small bowel resection or something like that is certainly again a possibility. Dr.
Sure.
Huang, is that something you
Dr.
guys are
Huang,
doing?
yeah, yes.
Yeah, Dr. Huang Wei, please.
Okay, sorry, can you repeat?
Sure. Do you think early on this injury might have lent itself to being treated with a laparoscopic small bowel resection as opposed to a formal laparotomy?
Yes, maybe such as patient as like this, just a need free gas and no peritonitis. I think first we do the laparoscopy, maybe a good choice. Thank you.
Yeah, I think
Okay.
that to your point earlier, if you find it, one of the problems is if you do go looking a lot, you may find things you don't know what to do with. You can see some bowels that'll beat up. Then the question is, do you leave it? Do you not? Certainly, if the bowel has a full thickness injury or has a gross bucket handle style injury where the mesentery is torn up, like it is on this one, you would want to resect. And I think I'd asked Dr. Reilly this earlier. What I would try to do laparoscopically is see as much as I possibly can with having had a CT scan to rule out major vascular injury, especially. That I would see as much as I could laparoscopically, and then make an incision that's smaller than a true, stem to stern laparotomy to bring that bowel out and try to keep it as tiny as possible and do externalize to do a small bowel resection and anastomosis.
Yeah. Great case, Dr. Li. Thank you so much for presenting it to us. You did a great job.
Very good.
Thank you.
Thank you. Okay, so I pass the host to Professor Carlos.
That's great. Thank you very much, Dr. Li, for presenting the case. Before we move on, I just want to acknowledge what a fantastic team of panelists and panelists and presenters we have here. So I'm going to really quickly acknowledge everyone. So we have Dr. Patrick Reilly, who's the Chief Division of Trauma, Surgical Critical Care and Emergency Surgery at the University of Pennsylvania Health System. He's also the immediate past president of the AAST. We also have Dr. Huang, Chief Physician from Trauma Center of Peking University People's Hospital. He's deputy leader of the Multiple Trauma Group of the Trauma Surgery Branch in the Chinese Medical Association. And we also have Dr. Patrick Georgoff, who is Assistant Professor of Surgery, Associate Program Director of the Associate Program Director of General Surgery and Associate Trauma Medical Director at Duke University. So thank you very much, the three panelists for being here today and being able to participate in this meeting. We're now moving on with Dr. Coile. Dr. Coile is a AAST Trauma SCC Fellow from UT Southwestern Parkland Trauma Center. She's a very good friend of mine now. She's helping me with the ultrasound course for the Pan American Trauma Society as well. So Dr. Coile, thank you very much for being here today. We are excited to have you here, and we are hoping to have a great case for discussion.
Thank you so much. Can you guys hear me okay?
Yep.
Okay, great. Can you see my slides okay?
Yep.
Yeah.
Thank you. Thank you for
Yes.
having me back. I enjoyed this discussion very much so a few months ago. So I'm presenting a complex blunt trauma case. This was actually a case from my second year of fellowship, and it weighs heavily on my mind. I was recently at Maddox, and someone presented a case that didn't go quite well, and that bravery really meant a lot to me. So I'm going to share a case that didn't go quite as well as I would have liked, and the patient did not survive this trauma. Uh-oh. Hold, please. Let's see if I can advance the slide. Okay. Okay, so these are my objectives. I want to go over triage dilemmas, things that get us off course in the trauma bay sometimes. I want to hit on a little bit of ABC versus CAB, although that literature is always discussing penetrating trauma. This is a blunt case, and sometimes when reflecting on this case, I think about how that may have influenced his hemodynamics, and then intercostal artery management. So I'm going to move you guys down so I can see. Okay, so we have a level 2 activation. This is what actually comes over on the pager in our trauma system. So activation for a 50-year-old male hit by some type of motorized vehicle at this point is all I know. Noted facial trauma, GCS of 10, 152/127 is his blood pressure. Notable narrowed pulse pressure there. 84 beats per minute, backboard C-collar applied, and his ETA is 2 minutes. So he's coming pretty rapidly. And within about 30 seconds, we had another page that he was quickly upgraded to a level 1 due to decreased GCS. I'm going to advance here. So he arrives pretty rapidly. Our EMS handoff provided by our professionals there added to the story that he was actually struck by an 18-wheeler going approximately 45 miles per hour. And his GCS is in waxing and waning in the ambulance. We quickly move him over and get our ABC interrogation. So he is moaning, and his breathing exam is notable for decreased left-sided breath sounds. He does have intact radial pulses, and we do quickly acquire a set of vital signs. Heart rate was still 84 beats per minute, and blood pressure was 153/127. Again, a very narrow pulse pressure there, and pulse ox is 84 to 97% on room air. And his respiratory rate was quite elevated throughout his trauma bay evaluation, 40s, sometimes up to 70s. Does anyone have any questions at this point?
Let's see, Dr. Reilly, Dr. Georgoff, Dr. Huang, do you have any questions for now?
No, I mean, I just, these people come in, I think, from a very simplistic one-person approach in the trauma bay, which not often how we publish. If you have an intact letter of your primary survey that's not correct, you should address it. So I guess you can make the case that he's got a respiratory rate of 40 and he's got decreased left breath sounds on the left. You should feel free in this day and age to do something about that rather than wait for diagnostic studies to be done.
Exactly.
That being
I agree.
said, you know, that all came down before you had a chest x-ray machine where you shoot it and the image shows up immediately and you can see it. So it's, you know, times they are changing, but I think you'd need to at least consider, you know, some of his quote unquote shock, if he has shock right now, is related to what's going on in his left chest.
What about you, Dr. Huang?
Such as this patient, the respiration rate is very quick, and the left side breath sound decreased. Do you have a chest X-ray or put a chest tube on the left side?
That's great. Dr. Georgoff, would you what would you choose between three options? Maybe X-ray, ultrasound, or putting a chest tube directly into the left side?
Well, I'd put a chest tube in if you don't have ultrasound or X-ray. It doesn't seem like this is the patient's collapsing in front of you. So ideally, some diagnostics in the form of adjuncts would help. And chest X-ray would be my preference. That's just out of my own personal practice. We do use ultrasound quite frequently, look for lung sliding. And if we don't have an X-ray machine, we'd be comfortable doing that as well. But I think knowing how to do both is a great thing as well to confirm diagnoses if you don't have something available. But yeah, I would definitely add on an adjunct before doing anything else if we could.
It's perfect.
I think the beauty of putting a chest X-ray in before any diagnostic studies is nobody can really question you about your decision.
Fair enough.
There's no X-way to second guess you or anything like that. You did it, you know.
Yeah. All right, Dr. Coyle, we move on.
Okay. So I did pose that question. And then just this is more of a learner type question, but just always want to point out the narrow pulse pressure.
Yes.
I think that's often missed when we can kind of consider the patients to be hemodynamically normal just because they have an elevated blood pressure, but they do have that narrow pulse pressure. And then thank you guys for pulling out the chest tube. So I'm going to go into more of our secondary survey before I show you the chest X-ray that we did acquire. We did not place the chest tube. So what became very distracting, I mentioned kind of trauma bay triage difficulties. This patient was amphetamine and cocaine positive. He was also in severe pain. I try to avoid using words like combative as much as possible. I think he was just in severe pain. He was crocodile rolling, and so it made access quite difficult. And so I was working with a first-year fellow, and we were kind of going back and forth about what medications we would like to provide this patient. And this caused a significant delay in our care. So over the span of the next 30 minutes, getting some trauma bay procedures done, eventually a left subclavian access was placed, an IO first, and then a left subclavian access. His blood pressure did become increasingly hypotensive. Whole blood was initiated. Secondary findings, in addition to the facial trauma that was already mentioned by our EMS providers, really only included a very large ventral hernia, which becomes quite pertinent later, but really no other secondary findings as far as external trauma.
Was he awake enough to say if he had a ventral hernia? You trying to give us is the patient awake enough to, you know, is this something he had, or is this something that you're going to tell us was caused by the semi destroying his abdominal wall?
This is a comment made by a man with a lot of expertise, because no, this is a chronic ventral hernia. Almost looks like an omphalocele defect. It is as if all of his small bowel has been on top of his abdomen for a very long time.
Oh, geez. Okay.
So that will come into play as this plays out.
Sorry, I have a question.
Okay.
Do you often use whole blood, and is there any difference between whole blood and red blood cell? How do you select?
Overall, I think the benefits of whole blood rather than a one-to-one replacement is significantly better as far as the amount of crystalloid and other products that are within the 1-to-1 replacement and has shown improved morbidity and mortality in those studies. So we're fortunate to have access to whole blood. Since this case, our EMS professionals are also administering whole blood in the field now. So we have access to whole blood until we don't, as far as our coolers there in the trauma bay. What about you guys? Are you guys pretty much always giving whole blood in the trauma bay now if you have access to it?
Yeah, this is Pat. You know, we have it in our trauma bay blood refrigerator, and so, you know, I would say it's become our default. We, you know, for certainly for our penetrating trauma patients, their pre-hospital times are so short. We don't give them any blood products. But if you know, Juan Chesney, when he was in New Orleans, had a wonderful presentation and then paper that came out where they put together a program in New Orleans for the EMS to be able to give people blood in very short pre-hospital time environments. So it's certainly something that is possible. But I would agree, in general, in the trauma bay, and a patient in shock, we're reaching for whole blood first. Now, we are, you know, still involved in some studies that are trying to look exactly what the answer is, because, you know, now the question is, how much whole blood do you give? You know, should you just give 2 units? Should you give more than that? Whatever. And so we're trying to do our little bit to contribute to the ongoing science of what exactly is the magic formula. But it's rare for us to give pack cells as the first blood product in the trauma bay.
Right.
Yeah, that's the same for us as well. You know, the thing that sticks out to me here is this the comment, and I think you put it in there intentionally, of over the next 30 minutes. You know, this is a patient who is quite sick. You'd made mention of, obviously, the mechanism is severe, the narrowed pulse pressure, and certainly the other findings on primary survey. You know, we teach here aggressively, and we're trying at Duke to get their time down. We're essentially trying to treat ourselves like a pit crew. And, you know, everything you do with this primary survey and adjuncts, and notice I didn't mention secondary surveys. Secondary surveys are great when you have time, but a quick, efficient, complete primary survey with adjuncts as needed is something that should be able to be done within a couple minutes. You know, certainly under 5 minutes. That doesn't always happen. There are things that stop you. Maybe you want to stop with the chest tube in. Maybe you do need access. Of course, things happen, but in a perfect situation, when it goes as quickly as possible. And then you're looking at a split. You know, for a truly sick patient, you are either should be going to the operating room or to the CT scanner as quickly as possible. And now, again, that's the ideal, right? There's always things that happen that make it very challenging in a trauma-based scenario, especially for blunt polytrauma, that leads you to be in the trauma bay longer than you would like to be, and that happens even to the best of providers all the time. But that is what I'm looking at here on this and saying, well, yes, now he's down to 80s over 50, sure, and there's all these things we're still worried about in terms of pathology when it comes to where is the bleeding, yes.
Yeah, excellent comments. Yeah, Dr. Coyle, I think you can move on. Yeah.
Yeah, I think there's so many intricacies here that slow up the process, right? So there's an IO that while you can give medication through, you're never going to be able to give large volume, fast blood that we're used to with the Belmont system. And so an IO and then a left subclavian access. And then, well, now he's just still crocodile rolling despite the fentanyl and the Haldol and all the medications in the world are not going to keep this patient still. He's a danger to himself. We've placed a binder. We've done all of these things. So, and we can't for the safety of himself and the team. So now we're going to intubate him, and really the progression to hypotension becomes, well, now we've given medications, but also we've intubated him. And so I'm going to always assume that the hypotension is hemorrhagic shock until proven otherwise, but it became quite a little bit of befuddlement of which came first. I assumed that this was hemorrhagic shock the whole time, but it just became a very convoluted situation because of all of the things and delays and things like that. So
did you have a chest and pelvic X-ray and fast at this point, or as you're doing these other things and intubating and whatnot?
Correct. Yeah, fast was negative multiple times. I'm going to go ahead and flip to, since you brought that up. This was our chest X-ray.
Yeah, listen, I've been in this scenario too. Anytime your fast is negative multiple times, you're like, what the heck am I doing a fast multiple times for? I mean, clearly I'm concerned I am marching down the wrong path here, trying to sort something out. And I have no idea the diagnostic accuracy of a fast exam in a patient who's got a ventral hernia and all their small bowel up in the a pouch of, whatever the heck's going on there.
Yes. So, there was also this pelvis X-ray, which I'm going to show you. Tiny bit of widening. It was red. There's some subtle fractures here, but nothing that would suggest that that was the source of his hypotension. So kind of triage the chest. There are some rib fractures, obviously, on the chest X-ray, but no large volume pneumo or hemothorax. And I would not say that the pelvis is an obvious source. A fast, as you mentioned, is not going to be very specific or sensitive, even in a patient with that. You can see how large the ventral hernia is there on the pelvis X-ray.
Yeah, Dr. Coile, his urine clear when you got a Foley in him?
Urine was clear, yes.
Okay.
So we were able to, with whole blood, to attain a normal blood pressure, 130s over 70s. I ask you, where are you going next?
Well, for me, you haven't really given me a great target. So I guess I'm going to CAT scan.
Okay.
Did you do anything with the left chest with the decreased breath sounds? Did they get better with intubation?
We, with the left-sided breath sounds, they were the same. It was still reduced. These chest X-rays were interpreted as pulmonary contusions. I'll tell you that is not what was going on, but that is how they were interpreted. Both
for the students out there, remember these things are all shot with patients laying supine, so you can't. Don't try to kid yourself looking for a meniscus or something like that for blood. You have to look at very subtle things. So, all things being equal, when I look at the chest X-ray that's up here, it looks like the left lung is whiter than the right lung, for lack of a better term. And so you would have to worry that there's a pleural effusion that's layering along the backside of the chest and something like that.
Yes.
And then the other thing in a patient that you always worry about, and I think we're in my shop, we're slow in the uptake to take it, is, we use our fast exam all the time and look at the belly. Maybe we look at the lungs, maybe we look at the IVC, but somewhere out there are some people with blunt cardiac injuries. And I think we're slow to use that ultrasound probe that up in the ICU, we can't help ourselves but doing a POCUS on somebody. And in the trauma bay, somehow that's a foreign concept to us. So I think it's something for us to keep in the back of our minds, that we can certainly use our critical care tool set in the trauma bay as well.
Absolutely. So we did end up going to CT. And these were all the injuries that were found on CT. I'm going to pull up the representative images shortly. But the abdominal injuries as well as the chest injuries are what are so significant here. Obviously, there's some hemoperitoneum. I'll pull up the relevant images here in a second. He does have some complete devascularization of the left kidney, as well as a little lack to the right kidney and left adrenal active hemorrhage. He has a grade 5 spleen lack, and then some facial fractures that correlate with his facial injuries. He did have left hemothorax, so it was pretty significant. And then some cervical spine injuries. There was never any pelvic injuries.
Great. As you're pulling up these images, Evelyn, I'm going to ask Pat a question.
Okay.
Pat, how do you guys PI your FAST program? I mean, to me, this patient sounds like they had a false negative FAST. If they have a ruptured spleen and hemoperitoneum and they had multiple FAST exams, and they're being reported as negative. How do you guys PI that?
Yeah, it's a great question, and it's certainly a focus of the colleges are coming around for their reviews. We rely heavily on our EM colleagues to help us with this relatively new, actually, PI process, so that they are very facile with ultrasound probes and they have immediate access to save images regularly. And so we run all traumas together. And so the EM team attendings or residents will set up the computer to be able to save the images. And then whether it's the surgical resident or the EM resident doing the scan, those images will be saved and then they're QI'd by our ultrasound leadership within emergency medicine. So it's a very...
Are you able to look at them in morning report?
So no, not right now, but that's also part of the back end is being worked on to allow us to have more access. And this is going in line with, we've started to get some cameras in the trauma bay for review to be kind of a holistic, everything's plugged in type thing where we can look at the even the intubation video laryngoscope and everything, ultrasound images, all that. We're trying to get that all pieced together so that we have a more complete picture.
Yeah, Evelyn, how do you guys do it?
I'm so glad you asked. As Carlos mentioned, I am a sonographer by trade before I became a trauma surgeon. So I just presented this at TQIP.
Interesting.
We developed both a qualitative and quantitative assessment, specificity, sensitivity for our ultrasound program that I led as a fellow for Parkland, where we actually initially started reviewing every single FAST. We had a 12% false negative rate. It was pretty needed some improvement. So we just did some dedicated education, both hands-on in the trauma bay, as well as dedicated teaching during our M&M process, just kind of learning the tenets of FAST. I think that sometimes we use simulation a little too much to learn something that is very technical. And when you're talking about patients that vary so much in size, they just don't look like that simulator. So you just need some more hands-on. And I think that was kind of where we were missing the mark, was just that hands-on. I'm going to lead you through how to do this on a very thin patient with a large ventral hernia defect. And I'm going to lead you how to do this on a 300-pound patient maybe who's going to have some difficulties. And all of those, you should be able to acquire a sensitive FAST, in my opinion. So I think that that dedicated hands-on training, as well as reviewing them during our M&M process, we've now reduced our number that we're evaluating each quarter to like a 10% of all of our FAST.
Wow, that's awesome.
Mm-hmm. So I have a representative image here. This is just the grade 5 spleen, and then I'm going to move forward and play this, hopefully. So it's just me thumbing through the abdomen, hopefully. So you can see the large volume left chest. This is a very large ventral hernia that I've mentioned several times. But mostly in the abdomen, it's just a spleen defect, grade 5 spleen. Sorry, that's a little fast. You have to take my word. It's the grade 5 spleen.
Do you
and
have
of course
extra in the chest or no?
I'm sorry.
Any extra in the chest there for the hemothorax?
Yeah, I'm going to show you the chest in a second. And then, of course, the left renal devascularization. And the left adrenal, I should say. Let's see. This is the chest. I want you to look in the posterior aspect of the left chest, just off the aorta. Tried to slow this one down a little bit.
Mm-hmm.
All right. So seeing the CT scans.
I'm going to ask you a question. This is just a pet peeve of mine. How do you guys confirm the placement of your OG tube in a patient like this? And do you I mean, we inflate some air and listen over the stomach, right?
Correct.
Do you put the thing on suction afterwards?
Yeah, I always feel like
Because
if it gets back,
we tend to confirm it, and then we never put it, then we go over to CAT scan and don't understand why the patient has a stomach full of fluid with an NG tube in it that, because we never put the thing on suction and gave it a chance to do exactly what we wanted it to do. It just strikes me that this patient's stomach is full with an NG tube that's in perfect position.
yeah, point well taken, Dr. Reilly. I always feel like if I'm getting back bile, I don't want to sit there and wait for another x-ray. So insufflation of the or the air that they insufflate through it is usually how the nurses assess it. I just feel like if I put it on suction and I see some gastric contents, and I feel pretty satisfied to move forward. With those CT scans, I was going to stop here and kind of assess where you guys were head first and what would you do first?
All right.
Well, I would have taken spleen out, but I don't want to go through the hernia. So I don't know how I'm going to do that, but that's so, I think that's part of the quandary is, are you going to go down a path of using IR and other methods to deal with the spleen because you are just, you're looking at just a tour de force of trying to get into his abdomen in a traditional way to evaluate all those things. And the other thing I'll just remind you, to our first excellent presentation that Dr. Lee did is that, this patient has, I think, at least 3 solid organs injured. They have the right kidney with a lac, the left kidney's got devascularized, and then there's a splenic injury. The number of solid organs that you have injured, as that increases, the chances that you have a hollow viscous injury somewhere increases as well. So you need to be aware of that this now, managing a patient like this without going into their abdomen, you have an increased risk of a delayed diagnosis of a hollow viscous injury. And again, I would look at this patient and look at the CAT scan and look at this patient and be shaking my head like, I'm not sure I want to do this.
Right.
Dr.
I'm just
Huang?
being honest.
I'm sorry.
That's what I would be thinking at 3 o'clock in the morning. Oh my God.
It is 3 o'clock in the morning. How'd you know?
Dr. Huang, what about you?
It's an interesting case. Maybe first I will take out the spleen, and second, sorry. First I will take out the spleen, and second for the left kidney, and third for other injury. Thank you.
Perfect. Dr. Georgoff?
Yeah, did you guys have any signs of hollow viscous injury, of any bowel injury on the CT at all?
No.
Yeah. So to Dr. Reilly's point, I would just be cursing the surgical and trauma gods. And was the spleen bleeding, active extract from the spleen?
There was some small volume hemoperitoneum, but no active extra.
And you do have active extract from, was that an intercostal that I saw right posteriorly there?
I have multiple active extra from the intercostals.
Yeah.
Off the aorta, very
So
close to the aorta.
if you have to decide what to, prioritize, the active bleeding area would be my area of interest. And with that, then I would think about what kind of interventional radiology assets you have, but also look at the patient. And if they're not doing well, continue to bleed, continue to get resuscitation, that I would take them for a thoracotomy to try to address this. If they are doing well with some initial blood product and have settled, and there's an interventional radiology team who can get things moving quickly, then I would certainly be happy to entertain that. And then at the same time, you could entertain embolization of the spleen, et cetera, all the while, to Dr. Reilly's point, worried about what other injuries you're missing in the abdomen and thinking, do I have to just bite the bullet here and try to get into the hernia? Or I don't think there's any, I was thinking about a subcostal and stuff like that just to take out the spleen, but I don't think that would really end up being a practical approach. It'd really end up just being a really terrible surgery. But if you have to do it, you have to do it. So maybe, but I would start in the chest. That is what I would say in terms of focus.
Great.
Yeah, I agree with that, Pat. Although this patient currently, he hasn't even have a chest tube in yet, does he?
Correct. He does not have a chest tube.
So I have no idea how. He's got a modest hemothorax right now. Maybe it's going to continue to bleed, but I want to say I would like some objective data before I go into his chest.
100%. So how is he doing in terms of resuscitation and response?
So he is becoming, after his return to from CT, he is becoming increasingly hypotensive. I would like to say that our ability to assess the CT scan in the CT scanner is great, but it has some fragments there as far as the remodeling of the scans. I could talk more about that, but it just takes a little bit for them to reconstruct them to a readable fashion. So it just took a little bit for that. In the meantime, residents did note the significant hemothorax and placed a chest tube, which immediately relented 1,500 cc's of blood. And he's becoming increasingly hypotensive, 70s over 50. So at that point, we did mobilize to the OR, just in the sense of time here. I just wanted to point out that that blood straight off the aorta. So we went to the OR. We did have 2 teams available to us. I mentioned I was working with a first-year fellow, so I had a kind of an ability to do 2 teams. So we did simultaneously do these operative explorations. XLAP, there was a jejunal injury. That one, honestly, probably was just from the mobilization of getting into that large ventral hernia and significant adhesiolysis. It did not really appear to be traumatic in nature. I think it was more from adhesiolysis, but nevertheless, a small section of small bowel jejunum was resected. And then, of course, the splenectomy was performed. It should be noted that once we took out, once we opened that abdomen, closing that abdomen was a huge transition point for the end of this case. And up there was not an option. I know that probably sounds silly to people who are very experienced with this, but then we just had a complete loss of domain. And so any attempt to put the bowel back in was very, very challenging. So we decided to do a pagoda bag. And just, I wish in hindsight that I'd just done towel clips around the pagoda bag. Instead, we whip stitched it around, which took a considerable amount of time. The left anterior thoracotomy was met with extensive bleeding. I could not visualize any source. It was just all welling up from the posterior. So we placed a considerable amount of combat gauze with the intention to go to IR.
Yeah, I might have missed this, Dr. Coile. How do you position them?
So he was positioned supine for the purposes of an XLAP.
Yeah, did you consider, we sometimes take these patients and put a long roll under the side that you're going to do and you know, keep them in spine precautions and then put an arm up, and you can sort of get a little bit more posterior with your thoracotomy while still doing a laparotomy.
Okay.
Just an option for somebody like this.
Okay. Yeah, I think that was a consideration too with the thoracic spine injuries that weren't unstable, but he was still in spine precautions as well. Would anyone do anything different for, I guess, would like to add anything to what Dr. Reilly said?
The only other is that sometimes where you're describing, sometimes we've used like bone wax and things like that in those kind of areas to help with control as much as a hemostatic agent, depending on exactly where the you know, the difficult bleeding is. When you're near the spine, usually for us it's with gunshot wounds or something like that. You know, sometimes we've learned this from our spine guys that just shoving a bunch of bone wax in there seems to help as much as the magic stuff that we use.
Okay.
Yeah, I'm sorry about this. I'm sorry about that chest, especially. I mean, the belly's terrible, but then this chest, those are frustrating cases where you have multiple sources of bleeding, and certainly you want to consider that this patient is spiraling into the DIC zone and trauma, coagulopathy after, you know, all the things that have happened so far, and that's a very tough place to be in. And to your point of packing and hemostatics, and if you have IR available, you know, certainly.
Dr. Huang, any other comments?
Such as this, we often use packing for chest injury.
Perfect. So, Dr. Coyle, I think that just in for the sake of time, maybe you could go all the way through the case, and then we can
Absolutely.
get more information from the panelists in the final comments.
Thank you. So I like to say it was quick, but 4 hours in the IR suite. Later, I was called back. It is our policy to always have someone in the IR suite with a trauma patient. But so that first year fellow did call me back to the IR suite because they were unable to ventilate the patient. And it was because he had a couple of liters of blood in the left chest. Despite the packing and, despite attempts to share decision making here, I would like to say that this note reads in the progression of the order of how they progress through the patient. But, despite talking with our IR colleagues, it really went in reverse, right? So they, attempted the left superior gluteal, and then they did the left adrenal and renal evaluation, and then they addressed the chest, which was the exact opposite of what I had requested. So this patient just continuously bled in the left chest, and to the order of a 6.9 pH and inability for anesthesia to ventilate him. And we had to open the chest there in IR just so he could be ventilated. T4 through T11 all had active extravasation from the posterior intercostal branches that were gel foamed. They did an additional sweep through after I evacuated the 2 liters onto their floor. And found another right-sided posterior intercostal artery that was embolized as well. So at this point, we did decide to go to SICU. The patient was significantly coagulopathic and hypothermic in the IR suite. We decided to continue resuscitating in SICU. The patient did end up getting a right-sided chest tube in the SICU. The left chest was open for a 3rd time in the SICU, again evacuating a large volume hemothorax after the patient continuously was unable to be ventilated. Additional packing, additional hemostatic agents for the 3rd time was placed. Combat gauze, gel foam, all those things. Persistent acidosis and coagulopathy in the SICU, and 8 hours later was the time of death. So,
right. Yeah, very difficult case.
Unfortunately.
Yeah, very difficult case.
Mm-hmm.
Dr. Georgoff, any comments, any final comments in this case? Any suggestions?
No, I think we've talked about a lot of this. Is unfortunate. This is a very, very tough collection of injuries to deal with, and these your team acted. You were active. You did what you needed to do, and you did not shy away from the challenge. And as things progressed, you got the patient to the operating room and did everything you could. When you get patients down to IR or anywhere else that's not the trauma bay or the OR for that matter, it can be tough to kind of lose control of them and lose time. And, that's to your point, you'd mentioned having a trauma team member there all the time. And, these things happen when it's not a trauma first provider looking after these patients. So a lot of very close teamwork and the presence of the trauma team oftentimes can help prioritize the sequence of events for things like this. And that's easier said than done when you are back in the operating room 10 minutes later with another laparotomy or whatever it may be in the middle of the night. These are very difficult scenarios. So again, difficult case, but great presentation. There's so much to unpack with it.
Yeah, definitely. Dr. Huang, any comments?
No, thank you.
Perfect. Dr. Reilly.
Yeah, I mean, first, thank you for presenting a case like this. It's never easy to present a case that, ends up not surviving. And I give you a lot of credit for doing that. And I think to Pat's comment earlier, if I had to look at this from a PI standpoint, I think you just got to go faster.
Yeah.
I mean, I think, showing a slide, and I understand why you did, but that, you're in the trauma bay for 30 minutes.
Yeah.
And you haven't done any definitive diagnostic studies and you haven't made a decision to go to the operating room is suboptimal. And I understand why it happened, but that to me is the biggest takeaway for a patient like this. And then you ask the question, and we get in this situation too, where do we go from here? I've gotten to the point now, if all of my diagnostic studies aren't turning up, just standing in the trauma bay and looking at the patient isn't helpful. And I will take a patient who's borderline and go to CAT scan with them. to get more information, because I'm not doing anything in the trauma bay. You know, I can't do a 6th non-diagnostic fast exam. That's I'm going to lose my mind with that. So, you know, it's different than it was years ago, in part because the CAT scans are so much faster and we can get information and drive us somewhere. And I think, you know, if I had to go back and try to change this, whatever, I would have gotten a tube in his left chest sooner to know that he has a big hemothorax, and try to get him to CAT scan sooner. And even if that meant you had to intubate him because he was crocodiling, or whatever the term you used is, and just do that and move it along. And then the other thing, just for the young ones, just remember, when you intubate a patient who's got a lot of pain, you have done nothing for their pain, except keep them from complaining so that you hear that they're in pain all the time. So you still need to address somebody's pain needs, even if you've intubated them and eliminated their ability to tell you that they have pain. We don't always do a very good job at that, to be honest with you. We looked at a study many years ago that looked at painful injuries and found that our patients who weren't intubated got a lot more pain medicines than our patients who were intubated, because they weren't complaining. And probably we weren't meeting their pain needs very well. Great case, Evelyn. Really, really well presented.
Quick question. Would anyone have gone to IR first? This is the point where I just really struggle. And I looked up posterior intercostal artery injuries, and it just is a ton of case study data, case review data, not a lot of large, you know.
Yeah, well, I'll tell you, we've embolized, you know, some intercostal bleeding, and it seems to have worked well. I got to tell you, I'm not sure that they had 8 of them bleeding like you did or something like that. You know, all these other injuries, it would have made me tough to make that decision. The one reason why I might have gone is because of that Fakakta ventral hernia they had. Just would have psyched me out so much that I would have said, let's see if we can't control things, so that if I do go to a laparotomy, I don't feel time pressured to do it quickly and maybe end up with that jejunal injury you got. Right. I totally understand how you ended up with a jejunal injury after trying to mobilize all those things in a rapid fashion. Totally get it. Although I got to be honest with you, we always would have blamed the trauma for it. We wouldn't have admitted that we did it ourselves.
But it all depends on how quickly IR is available and how sick the patient is. If you're putting a whole bunch of blood into them, the only place they belong is the operating room, right?
Yeah, I got to say, I was at you know, an international trauma conference in Japan, and the guys in Japan, this one hospital was doing a presentation, and they showed this like ATLS picture of the trauma bay and where everybody's standing. And in their level 1 activations, the right groin, there's a little person there, and it's the IR doctor who literally is in-house and meets the patient, feels that pulse in the right groin so that they can stick it to get access for a rapid IR intervention, or a rapid. I mean, it's very interesting. Like you, we struggle for IR to you know, get them there in a time fashion that we would like them to be there at. But there are other places around the world that have much more rapid access to IR. And in a patient like this, that might have been very helpful.
Great. Thank you.
That's great, everyone. Thank you very much for being here today. I'm sorry that we went over 10 minutes or 12 minutes here for the presentation, but the discussion was so fantastic that we could not stop discussing, right? We asking questions and answering. I mean, it was a fantastic presentation and a great discussion. Dr. Zhang, thank you very much for being my co-moderator for this session. I also want to thank the panelists again for being able to be here and to share the knowledge and their expertise with us. It was really, really interesting. Dr. Coyle and Dr. Lee, thank you very much for presenting the cases. These are very challenging, and the discussions went very, very good. I hope to see you all next month in the same meeting, and also next week for the PTS, the Pan American Trauma Society meetings. You are all invited. Please feel free to join, and we are going to have another great discussion as well. So thank you very much, you all. Bye-bye.
Take care.
Thank you very much. Bye-bye.
Bye-bye.
Thanks, Carlos.
Bye.
Thanks,
Thank you.
everybody.
Bye.